So thank you all for joining us this afternoon. Today's lecture will be given by Dr. Alexander Vaccaro, spine surgeon and president of Rothman Orthopedics. Dr. Vaccaro has served as the president of Rothman since 2014 and is the Richard H. Rothman Professor and Chairman in the Department of Orthopedic Surgery and Professor of Neurosurgery at Thomas Jefferson University. Dr. Vaccaro sees patients in our Center City office and operates at Jefferson Hospital, Methodist Hospital, and Rothman Orthopedic Specialty Hospital in Bensalem. Go ahead, Dr. Vaccaro.
Natalie, thank you so much. It's an honor to have this opportunity, and I think it's really interesting that we do it at lunchtime, which I think is great. I'm dressed in my little outfit because I'm between surgical cases, and believe it or not, my next patient who's about to have spine surgery is most likely streaming this right now as they get her ready for surgery after this course. So I wanted to talk about something that we're using a lot of now, and that's using technology to help us in the operating room. And this doesn't mean it's safer. It's a different way of doing surgery using a robot that has all the values of a robot. But it's, as you can imagine, it doesn't do the surgery for us. It just helps us do that. So I'm going to take us through a little tour. I have a conflict. I do work with a robotic company. So we see robots in almost everything we do. I have an electric car. It uses artificial intelligence. Our smartphones use robotic technology. We use airplanes, and anything we use nowadays has some sort of automated service using artificial intelligence, which is fantastic. So the robots are here. They just may not look like robots, but we're using it in everything we do. And you see the manufacturers touting this technology. It's safer, smaller scars, shorter hospital time, lower risk, faster overall recovery. And that's not really true. You can do minimally invasive surgery a lot easier because instead of using fluoroscopy and using loops, which is what I use, and here's an example, this is what I'll be using today when I operate, the robot sees all these things for you. But we have not been able to translate that into two things at the present time. One, time efficiency, and two, improved outcomes. We have decreased radiation for the patient and the OR staff. I think that's true. So these are the things that we have to think about. Now, you don't have a robot in the operating room doing the surgery. We basically have a computer assisting us doing surgery. That's all it is, basically. And there's three different types of surgical robots. And the FDA has approved in spine surgery a shared controlled spine. We tell the robot what we want to do. The robot tells the computer what it should do. And then we have to be the end effector. We have to actually press a button, watch the robot do exactly what we want it to do as we visualize to make sure it's safe. We're not telling a robot what to do and sit in the back of the room. That's not what's happening with a robot. Now, what does the robot do for us today? Well, it makes cuts in bone more accurate. It puts screws more accurately. We want to place them. And keep in the back of your mind, well, then why doesn't everyone use a robot? Because putting a screw 1 millimeter to the left and 1 millimeter to the right may not affect the outcome. Now, what will affect the outcome if you keep people under anesthesia less, you can get them up sooner. And if you could take a very complicated procedure with high blood loss and make it a smaller procedure with less blood loss, and that's important. So for me as an orthopedic spine surgeon, I don't think it's useful for very simple cases, but I think it's very good for revision cases if I have to come back and do an operation again that someone else did and there's a lot of scar tissue. If I have cut the bone, take a look at this picture. This is a really bad scoliotic deformity. Three-dimensionally, I'm only looking at a two-dimensional fluoroscopy when I'm in the operating room. But a robot, in their mind, can see things in multiple dimensions and basically take me to where I need to go. And then I confirm that's the accurate cut, and it goes ahead and does the accurate cut. So that's what it's great for me. And this picture just shows us that, like right now when I do scoliosis, you put a bunch of screws in and you're like, oh, I got the screws in. Now you got to figure out how to push the spine into the right alignment. Then you have to put the rod to attach to the screws. And all of a sudden, some of the screws are in deeper, some are less deep, some are to the left. The robot basically says, all right, fine. And the robot tells you how to make all the screws perfectly aligned and at the right height. So little things like that, you don't have to do because the robot does it, which I think is phenomenal. So the robot gives us that. Now, what's a disadvantage? Well, it's a robot actually doing the end effector maneuver. So you're not feeling the instrument against the human body. You need to train everybody. And by the way, robots are expensive. $1 million for a robot, an extra $1,000 for every case. So these are very expensive things. And I say all the time, you have to be there working with this technology because technology sometimes fails, and you don't want to be in a situation where you're blind and all of a sudden your instruments fail and then you don't know what you're doing. So I always say you have to train as a traditional surgeon. So all you have is a scalpel and a tool, and you can do the operation. You don't have to rely on big technology. Now, my interest, this is a paper we wrote at the end of the 1990s, looking at the value of using computer-assisted technology. We looked at using the normal way of doing it. We used looking at a CAT scan and fluoroscopy. We looked at using image guidance. And what we found was when you use image guidance, it's more accurate. Again, not a difference in safety, not a difference in outcome, but it's more accurate. And then we did a more recent study where we worked on cadavers. Then we worked with the robot. We worked with just using it the way we do it today. And we're using it with fluoroscopy. And again, 2020. So this is 20 years later. Before we just had a computer-assisted navigation. Then we had a robot with computer-assisted navigation, and the robot's more accurate. And then the more complicated areas for spine surgery is like operating on the neck and the thoracic spine, where you have the spinal cord. It's dangerous. And if you look at, I won't get into these studies, but if you look at every study, it basically shows there's no error or very little error in the cervical and thoracic spine. So it's a great technology. Now, this is way beyond the scope of this talk, but the technologies that are approved by the FDA is that we use optical tracking. We have these like little light emitting diodes that get picked up by a camera that gets registered to a computer. And it's a real pain because all the instruments have to have these diodes and it has to see the camera. So if you put your head in the way, if someone looks over, you block the vision, the robot stops. So we're waiting for Bluetooth or electromagnetic. We can't use it right now because it interferes with our anesthesia machine. It interferes with other things in the operating room. So it's not there yet, but I can't wait until Bluetooth is around because then you don't have to have line of sight anymore, which would be fantastic. So that's just something interesting. So when I started in the late 1980s and early 1990s, we had very simple robots that came out in the end of 1990s and the end of the 1980s. And I was participating in a lot of different cadaveric and research studies. And now we've sort of evolved to these complex robots. Now we have robots that can be carried around in a suitcase and brought to an ambulatory surgical center, which I think is phenomenal. So I think that is where we have to be. So I just think it's a wonderful technology that we have. So that's wonderful. That was the anesthesiologist asking when to do it. And I said, wait until I finish my talk and then we can put her under. So this is the robots we use now. We use robots that have things placed in the body that allow us to know that our imaging is accurate. And if you look down here, that little picture, you see two little antennas. Those antennas have to maintain a distance. And if anything moves, like say you bump something, it tells us the navigational system is off and we have to stop what we're doing. So it's interesting. Now I'm going to go through a bunch of papers and I don't like any details. I'm just going to tell you in a few words what they say. This is just all the world's literature looking at the accuracy. And if you look at the numbers, anywhere from 92 to 100%, which is phenomenal. And then I looked at all the different studies that came out recently, 2000, 2021, 2022, more accurate than freehand, no difference in outcome. Basically, radiation is less. Another study, more accurate than freehand, superior. Violation of structures shouldn't be violated, less with a robot, which is great. And then what I like to study is well, when does a robot not work very well? Well, with any type of individual that has a large body girth, imaging is difficult, and you need to have imaging to show the robot where the patient is in space. So it's less accurate in obesity, less accurate when the bone is not usually visualized if they're osteoporotic. And then if you have really bad deformity, sometimes there's volume averaging and sometimes the robot can get confused. So you have to keep that in mind. And if you look at the more contemporary papers that look at complications, the complication rate is about equal. It's really not that difference between open and closed, which I always thought was interesting. And then my PowerPoint stopped. Okay, there it goes. The thing I like the robot the most, and I think patients should like it the most, is that you're not using intraoperative fluoroscopy. You're not radiating someone constantly, like minimally invasive surgery. Bring the fluoroscopy in. AP, lateral, AP, lateral. AP. Surgeons exposed, anesthesiologists exposed, patients exposed. With the robot, we're developing MR technology so you can get a preoperative MRI scan, merge that with the robot, and there's no radiation at all. So it's phenomenal. And these are just studies that look at if you're using traditional minimally invasive techniques using fluoroscopy compared to a robot, the fluoroscopy is a lot more radiation. So always ask your surgeon, are you doing minimally invasive surgery? Are you using any type of method to minimize my radiation exposure? The other thing, which I think is interesting, is we study learning curves. Anytime you have a new technology, there's a learning curve. And you always say as a patient, well, I don't want to be part of the learning curve. I want to be when that surgeon is great. And with a lot of technologies, when you learn how to be really skillful, once you think you mastered it, you haven't mastered it. You need more time, because there's always a peak, and all of a sudden you have problems, and there's a peak. I see this in every learning curve. I got it. Oh, no, I don't got it. And I got it. So like anything else, make sure your surgeon has a lot of experience in it. And some say you have to have up to 80 cases before you become an experienced surgeon. Now, if you look at operative times, I clearly believe the operative time is increased today for a robot, because there's a lot of different steps. And we've worked on the accuracy and the safety, but we haven't worked on the time efficiency. So these studies are published, no different, but really in general, it's increased time. And we just pulled over cases of Thomas Jefferson together, and we compared it to doing it to traditional open way or minimally invasive way. And we basically said it's the same. So there's no, so if your doctor doesn't have a robot, it's not going to affect the outcome. It's just another tool that a doctor uses. And then if you look at the cost effectiveness, and these are always amusing papers to read, because you have to really look at the details. Intuitively, it's more expensive to use a robot. And until you change the outcome, or until you can do more patients safely in an operating day, it's not going to be cost effective. But if you read the literature, you get confused. Like this paper said, once you get to the 254th case, it becomes cost effective. This one said, listen, you have less OR time, less revision rates, less length of stay, so it's cost effective. You save $2,700 a case, which has not been our experience. And then another paper said, listen, this is great, less infection, quicker instrumentation, better, more accurate. And this says in 1 year you could save more than $500,000. But this study basically says, and these are from people who are not conflicted, that says, look, let's take a look at everything. Let's look at robotic cases, look at MIS cases, let's look at open cases. And basically they look at cost per quality. A quality life year, I mean, we rate someone's utility. That means health or bad health. 0 means you're dead, 1 means you've got great health. And then we look at what would you pay to get a 100% great quality of life. And you can see that robotic is actually more expensive. If you used MIS techniques, it's $116,000 per quality. The United States can pay up to $150,000 per quality. Great Britain will only pay up to $50,000 per quality. But if you look at a robot, it's $593,000. So the literature is a little bit confused. So in real world, I love the robot. If you have a large body weight, it's more difficult. I make sure when I'm training fellows that they have at least 100 cases under the belt before they go out and use it. You have to make sure you have the right equipment, and you need the right table, you need the right sterilization equipment, you need the right draping. And then the robot right now takes a lot of time. You have to introduce the robot to the imaging system. The imaging system has to introduce the data to the robot, and then you have to confirm that. So, and then you have to use the line of sight technology, which we have now. So we have gone from this in assembly lines to this at the present time. And I always laugh how the car industry and all the other industries, space industry, had all this technology, and why did medicine have to wait? And I have no idea. But I think in the future, we won't use CAT scans. We'll use MRI scans. We'll have things that will just be able to use light and look at the topography of the patient. And then that will be evaluated in light of the imaging studies before surgery. And you'll be able to take a patient in space and then merge it with the preoperative imaging studies to tell the robot exactly where it is. And we'll have smart tools that we'll use that can help navigate to soft tissue. So right now the robot just takes you where you need to be. But if there's a great vessel in the way, if there's a nerve in the way, that can cause a problem. But with these robotic technologies, with smart tools, it senses the difference in impedance in tissue, because, oh, that's a vessel, let me move over here. Well, that's a nerve. We don't have that today, but I think we'll have it in the future. So this was just sort of an introduction to a really interesting form of technology that will take us where we need to go in 10 years. We're in its infancy now. We love it at the Rothman Institute. We're all using it. We think it's great, but there's more to come in the future. So thank you for your time. I always like to speak short because I know you don't have much time for lunch. So I want everyone to eat an extra sandwich because you have some extra time on your plate. Well, thank you.
Thanks, Dr. Vaccaro. And we did record this, so we will send this out so you can review it at a later time. Everyone have a great day.